Welcome back to our Cardio-ECHO clinic, your patient with diabetes at risk for heart disease series of case discussions. We are already on week 8, so good morning, and we should have a great clinic today, so I'll go ahead and hand it off to Dr. Rao.
Thank you, Jesse, and thanks again to everyone for joining us for our 8th week. It's hard to believe 8 weeks have gone by already. A couple of very interesting cases today. And we've asked Karen to discuss both of these cases. I think a very, very interesting one from the usual standpoint of issues of adherence, but also a young person too, so which I think makes this really interesting. We have a couple of didactic presentations. I'm going to present slides that were presented last year by Sadir Al-Kindi, who's one of my colleagues at University Hospitals in the Cinema Center. The Cinema Center works closely with our Fit or Me obesity program. So bear with me. I did adapt his presentation to the best of my ability, but I want to focus on a few key messages. And similarly, Dr. Werner is going to discuss his section in an abbreviated form. We've got 2 great cases as well from Drs. Murphy and also Sherry Thompson, and we'll get started. Next slide. These are our disclosure statements. Next slide. Again, a reminder to use patient-centered language as much as possible. I do believe I've gotten a little bit better with that myself, and I hope that it's not an instant process. It takes some time to adapt to it. So I will do my best as we move forward. Next slide. So this first part of the presentation, before we turn things over to Jim, is about cardiovascular risks in diabetes. And I think if there is a unifying message here that Dr. Al-Kindi wanted to convey, is that you do not treat diabetes in isolation of other cardiovascular risks. And this is something that's been around for a very, very long time. So the idea that you go and you see your doctor, you have your diabetes taken care of, the blood pressure is not addressed, or the lipids are not addressed, or the smoking is not addressed, makes absolutely no sense whatsoever. Next slide. So these are our 3 objectives, some basics on managing lipids, blood pressure, chronic kidney disease, and in someone with established heart disease, this is secondary prevention. And then Dr. Werner will discuss some basics of smoking cessation. Next slide. So this is, I think, a really meaningful slide because it shows you the enormous impact that diabetes in conjunction with established coronary heart disease has upon CVD mortality and coronary heart disease mortality. CVD meaning encompassing, of course, stroke, et cetera, and coronary heart disease mortality. If you have not, this is the relative risk. So if you're looking at 6 or 7-fold in terms of CHD mortality once you have CVD and diabetes. And of course, if you have metabolic syndrome, which is that constellation of other signs of insulin resistance, then you have an increased degree of mortality. But diabetes is overwhelmingly important in promoting mortality among those with heart disease. Next slide. This is another slide he had put together. Diabetes complications, essentially. So there had been some improvement. But you start to see that really not much change in the last 15 or 16 years or so in terms of mortality, morbidity from end-stage kidney disease or amputation. So it's one of those things like some forms of cancer. We really haven't made a lot of progress overall. And of course, a lot of this is driven by the increased incidence of diabetes in turn fueled by obesity. Next slide. This, I think, was a slide that is often put forth, and I think it's more complicated than this. I mean, how do we define optimal therapy? So this is optimal therapy in terms of cardiovascular medications, lipid-lowering medications, and glucose-lowering medications overall. So we can define optimal therapy as each of these conditions being controlled to some extent, but you'll notice there isn't explicitly a call out for blood pressure here. But are your lipids under control? Is your diabetes under control with various agents? And are you on an antiplatelet and an ACE inhibitor, of course, which preserves LV function and kidney function? And you can see that many people are taking these medications, but the combination that results in optimal medical therapy is very low, 7%, less than 7%. And I do think the reason is because our care for patients with diabetes and other cardiovascular risks is so fragmented. If there was an approach that would make sense, it would be a unified cardiovascular risk assessment and addressing all of those issues in concert with one another. So for example, a patient can come in with diabetes, but you'll say, yes, but I've noticed you do smoke, you have obesity, you have dyslipidemia, you have uncontrolled blood pressure. Which one would you like to work on first today? And we will address these collectively, because as I said, it doesn't make any sense to address one and not the others. Next slide. Now the pathways linking, this is a very interesting slide from Newman. Pathways linking type 2 diabetes with cardiovascular disease. So you will see that there are drivers of type 2 diabetes, physical activity, poor diet, obesity, smoking. Although I'm not sure how smoking is a driver, but certainly many patients with type 2 diabetes smoke. And of course, the disturbances in type 2 diabetes result in other issues such as dyslipidemia, which in turn can have an impact upon glucose control as well. So one of our colleagues, Dr. Raj Gopalan here, it was our head of cardiology, is very interested in the role of environmental pollution upon metabolic risk overall. And of course, you get a bidirectional endothelial dysfunction, stiffness, inflammation, oxidative stress, and of course, thrombosis and coronary heart disease as well. So it's a complex mechanism. I think if there's an initial driver, it really is a poor lifestyle at the outset. Next slide. So these are recommendations, and of course, very, very few of patients with type 2 diabetes are pursuing a lot of these or are receiving services in this sense. So physical activity, 150 minutes per week minimum, moderate intensity. And then you have some resistance training from the CDC that's recommended as well. Dietary management, weight management, smoking, glycemic control, blood pressure, cholesterol, and antiplatelet therapy. Some of these are easier for patients to pursue than others, but in general, as Dr. Al-Kindi noted, very, very small proportions of patients are on all of these. So I think if there is a recommendation, I would say, well, I don't want to address your diabetes by itself, because why do I want to address your diabetes? Of course, glucose control will make you feel better, will prevent complications such as eye disease, kidney disease, but I want to address all of your risks for heart disease and stroke, and that includes a number of issues that we've already discussed. Next slide. This is the actual benefit that you get from various interventions. So aspirin, modest benefit, statin, this is in terms of reducing the number of events. And I think that the thing to note here basically is that if you are on medical treatment and pursuing a lifestyle, and lifestyle, by the way, doesn't, in this particular case from Newman, doesn't refer to a weight loss necessarily, but it can be physical activity in the absence of a significant weight loss. But it's being pursued regularly. So there is a whole phenomenon of the metabolically healthy person with obesity, which has interested me for some time. And the difference between those people and people who have obesity but have significant metabolic disturbances is the level of physical activity they pursue. So this gives you an idea of the enormous benefit of lifestyle changes upon patients with type 2 diabetes. Next slide. Okay. And I'm going to turn things over. I promised about 5 minutes. I think I stuck to it. Turn things over to Dr. Werner for a few minutes.
Yeah, great. Thank you, Goutham. Good morning. We know that smoking is a risk for all patients, but it poses special risks for poor outcomes in patients with diabetes. So helping these patients stop smoking is particularly important. Next slide. So health-related events such as a diabetes diagnosis or hospitalization, triggers more attempts on the part of patients to quit smoking, and it improves their rates of smoking cessation. So this is a teachable moment or good opportunity to help patients quit smoking. Unfortunately, fewer than 1/3 of patients use evidence-based methods, and this is where clinicians can really help them in their quit attempts. Next slide. So the good news too is that evidence is very strong for physician and nurse advice being effective in stimulating patients to make quit attempts and to be more successful when they do attempt to quit smoking. And it doesn't take a lot of time. So brief in-person counseling, less than 10 minutes, has been shown to increase the proportion of adults who quit smoking and remain abstinent for a year. And even minimal interventions of less than 3 minutes have been found to increase cessation rates. So your position as a primary care provider is a very high leverage position as the patient's health expert. So coming from you, your words have a great deal of weight with patients and can make a big impact, even if you don't have a lot of time to spend. Next slide. So you may have heard of ESPER, screening, brief intervention, and referral to treatment. It's a basic framework for helping people with substance use disorders, including tobacco cessation. So what we're going to do is use this framework along with some of the techniques that we used when I taught motivational interviewing a few weeks ago, and just kind of walk through a hypothetical case of how to work with a patient who has diabetes. Next slide. So after establishing rapport, and that's particularly important because really the relationship you have with the patient is the catalyst for behavioral interventions in primary care. So that's always important. So establish rapport, reestablish it, and then a clinician could ask, Mrs. Williams, do you currently smoke or use tobacco? She says, yes, I smoke. And then an optional step is to assess how many cigarettes per day is she smoking, what is her level of dependence. It's not necessary, but it can be valuable. Okay, then we move into the brief intervention phase of the ESPER. So as we talked about before, the technique of opening the door with developed by Dr. Goutham Rao here is to express concern. I'm concerned about your smoking, and then link it to a salient health condition. Here it's diabetes, of course. So smoking makes it harder to control diabetes. It also increases your risk of developing serious health problems from diabetes. So just very clearly stating what the health risks are with respect to diabetes. And then to ask, does this concern you as well? And she says, yes, it does. And then the next step is ask permission. Can we discuss this for a few more minutes today? She says, yes, that would be fine. Then we can use the scaling question for motivational interviewing. On a scale of 0 to 10, how important would you say it is for you to quit smoking? Where 0 is it's not at all important, and 10 is it's the most important thing for you right now. Okay. With that question, what we're able to do is to stimulate the patient to think about their reasons for quitting smoking, as well as really help us understand where they are in the stages of change. So once again, we ask if they currently smoke, we express concern, then link it to their medical condition, ask if it concerns them, ask permission to discuss it, and then you can move right into using this motivational interviewing technique, which really you get a lot of information and really help the patient start thinking about reasons to quit with that single question at the end. Okay, next slide. So referral for treatment is the next step. So we talked about screening, brief intervention, now referral for treatment. Next slide. So you may be familiar already with the Ohio Tobacco Quit Line, is a tremendous resource. So they provide really professional health coaches providing telephone counseling. They also have an online program where patients can track their quit attempts and their progress. This is done in English and Spanish. They have a translation service available. I called them yesterday. They do have still up to 8 weeks of NRT available for more than 90% of patients who call the quit line. So it's a resource for these materials. Also, Medicaid covers NRT, as you're probably aware. Patients can also do phone only or online only if they want. So it can really be tailored. They also have a really nice suite of different interventions available through the quit line for teens, for those under 18. So that's also a great resource for those kids who are starting to smoke. Next slide. You may have heard of the Freedom from Smoking program from the American Lung Association. They also have helpline counselors and apps. They have in-person 8-week-long facilitated groups as well for those who would prefer that approach. And these are also done by Zoom nowadays. And they offer NRT. So if you're not able to get it through the Ohio Quit Line, this is a good resource too. Next slide. Smokefree.gov is sponsored by the National Cancer Institute. They have counselors in English and Spanish. They also have a really nice suite of texting, smartphone apps, and social media for people who prefer those kinds of interventions. And so they also have tailored texting apps for women and teens, veterans, Spanish-speaking patients, patients over age 60. So they really have done a great job of targeting specific groups and tailoring their messages to these groups. Next slide. So for those who aren't ready to consider making a quit attempt, we know the evidence shows that providing printed information about smoking risks and cessation methods can be helpful for them. And then I think most importantly, ask permission to resume this discussion at a future visit. So you leave that door open so you can touch base with them about quitting smoking, about have you thought any more about that since we talked last time? And we know that these periodic check-ins with patients are effective. So you may not have 30 minutes, but you do have repeated opportunities to revisit this with patients as they've kind of perhaps moved through stages of change on their own as they thought about the conversations you've had with them between visits. So at subsequent visits, you can use the brief MI techniques that we talked about to build motivation and self-efficacy. Next slide. So to recap, you can use the opening the door technique, plus the SBIRT approach, screening, brief intervention, referral for treatment, and then motivational interviewing. Refer patients to these resources that we discussed. And for patients who aren't ready, ask permission to resume this discussion at a future visit. You can support them if they're not ready to make a quit attempt to move through the stages of change. Okay, next slide. Next slide, there we go. There are additional resources for quitting, including things like Nicotine Anonymous, which is a 12-step approach. And there are meetings in the Cleveland area. There are also Zoom meetings available, as well as other resources. Okay, thank you.
Thank you. Thank you, Jim. And we'll have a minute or so for any questions for Jim or for myself.
I was on a meeting the other day that's a coalition of, healthy lifestyle. It's just all kind of organizations, including the library and health department. And I found out that the local library will check out iPads to people. And so that they can do virtual appointments and things like that. And they have some way of making sure that there's internet connectivity. So that's a resource I didn't even know we had. And so that might be kind of interesting to check out the local library and see whether they have something, just so that you can at least have some contact with, or maybe virtual appointments. Or maybe the diabetes self-management can start to.
We have that too here in Cleveland, Karen. It's mostly for seniors, and it's not because they don't have a device, it's because they don't know how to log into the virtual appointment. So the library person will actually, it's not just issuing them an iPad, they'll help them get set up, and they can go into a private area and do their appointment there as well.
Well, that's pretty cool. Maybe she could take the baby to the library, maybe, use the iPad and do a virtual appointment.
Mm-hmm. Great suggestion. Okay, Jesse, back to you.
Sure, thanks everyone. So the post-clinic survey should be in your inbox. Thank you for all the great feedback. And I think most of you have already updated your contact demographic form, which is also great, much appreciated. But if you haven't had the opportunity to do so, if you could complete that by next Friday, that would be great. And let me know if you need me to resend the link. I'm happy to do that. And then just a last reminder, we do have a cardio webinar coming up on December 1st over the lunch hour, and there's a registration link there, but you can also just visit our website, cardio.org. It should be very interesting, and just wanted to let you know of another opportunity. So with that, I think it's 9 o'clock, and thanks very much. We'll see everybody next week.
Thanks, everyone. See you next week. Bye-bye.